हेलो, नमस्ते, गुड इवनिंग एवरीवन, खुशामदीद। आज का हमारा ये जो एपिसोड है ये काफ़ी स्पेशल है। मैं हूँ आपकी होस्ट और दोस्त डॉक्टर विनी कांट्रू। मैं एक पल्मोनोलॉजिस्ट और क्रिटिकल केयर स्पेशलिस्ट हूँ नई दिल्ली में इंद्रप्रस्थ अपोलो में। और आप सभी को गणतंत्र दिवस की बहुत सारी शुभकामनाएँ। ये एपिसोड जो 563rd एपिसोड है हमारा डॉक्टर केके's मेड टॉक्स का, इसमें हम आपके सामने सभी लीडिंग जो एक्सपर्ट्स हैं अपने फील्ड में, उनको लेकर आते हैं और चाहते हैं कि आपकी जो नॉलेज है, जो मेडिकल नॉलेज है या हेल्दी रहने का तरीका है, वो काफ़ी अच्छा हो जाए। सभी लोगों को जो हमारे साथ जुड़े हुए हैं, उन्हें गणतंत्र दिवस की काफ़ी शुभकामनाएँ। ये आज का हमारा एपिसोड काफ़ी स्पेशल है क्योंकि आज हमारे साथ एक स्पेशल दोस्त है जो कि इंडिया में नहीं है और दूर देश में वो प्रैक्टिस करते हैं मेडिसिन, काफ़ी स्पेशल है। कोविड-19 के पेशेंट्स को काफ़ी अच्छे से ट्रीट किया है उन्होंने, यहाँ तक कि उनको अवार्ड मिला है कोविड-19 के पेशेंट्स को 2021 में ट्रीट करने के लिए। So let's go to the headlines of the day. तो हमारी जो आज की हेडलाइंस है, उसमें भी ये काफ़ी स्पेशल है कि साइरस पूनावाला जो कि सीरम इंस्टीट्यूट ऑफ इंडिया के सीईओ हैं और उनकी वजह से ही हमारे पास जो वैक्सीन मैन्युफैक्चरिंग की क्षमता है, वो इतनी ज़्यादा है। उन्हें और कृष्णा इला और सुचित्रा इला को अवार्ड किया है पद्म भूषण, द कंट्रीज़ हाईएस्ट थर्ड सिविलियन अवार्ड्स। इट इज़ अ मैटर ऑफ प्राइड फॉर ऑल ऑफ अस कि इन सबको ये अवार्ड मिला है और आज हम ये कह सकते हैं कि इंडिजिनस वैक्सीन्स का हमारे पास एक ऐसा मौका है जिसमें कि इतनी हाई लेवल पे प्रोडक्शन होता है। रिकॉर्डिंग इन्फेक्शंस ऑफ कोविड-19 अगर उनकी हम नंबर की बात करें तो इंडिया हैज़ क्रॉस्ड अबाउट 4 करोड़ number of COVID-19 infections on Tuesday. The country reported 2.85 lakh new COVID cases with a positivity rate of 16%. Pfizer and BioNTech have started enrollment for the clinical trial to test their safety and immune efficacy of of a vaccine which is specific for Omicron variant. और ये उन्होंने शुरू किया है 55 साल की उम्र के लोगों के लिए। उन्होंने बताया है कि ये जो वैक्सीन है, ये मार्च तक अवेलेबल हो जानी चाहिए। द ओमिक्रॉन वेरिएंट अपीयर्स टू रिजल्ट इन लेस सीवियर डिजीज जो कि हम देख ही रहे हैं। ये स्टडी आई है यूएस से जहां बताया जा रहा है कि नंबर ऑफ हॉस्पिटलाइजेशंस जो हैं वो काफ़ी कम हो गए हैं और जो सीवियरिटी है डिजीज़ की, जो तीव्रता होती है हमारे कोविड-19 पेशेंट्स के प्रेज़ेंट करने की, वो काफ़ी कम हुई है इस वेव में एज़ कंपेयर्ड टू द प्रीवियस डेल्टा एंड अल्फा वेव्स। ये तो हम यहाँ भी देख रहे हैं क्योंकि जितने भी पेशेंट्स हम अभी देख रहे हैं, वो ओपीडी बेसिस पे सब ट्रीट हो रहे हैं और ट्रीट होके अच्छे स्वस्थ हो रहे हैं। इसका सबसे बड़ा कारण ये भी हो सकता है कि हम सब जो हैं वैक्सिनेटेड हैं, तो वैक्सीन के बाद वैसे ही जो है तीव्रता इन्फेक्शन की, वो काफ़ी कम हो जाती है, जो सराहनीय है। हमारी कंट्री में इतनी लेवल पे वैक्सीनेशन पे काम हुआ है, वो काफ़ी सराहनीय है। जो हमारे पैरामेडिकल स्टाफ हैं, जो दूर दूर तक जाके चाहे बर्फ हो, चाहे गर्मी हो, सब लोगों को वैक्सीन लगाने की कोशिश कर रहे हैं। ये भी काफ़ी सराहनीय है और गर्व महसूस होता है कि हम इस देश से हैं और इस तरह लोग सेवा कर रहे हैं। Addressing the nation on the eve of Republic Day, President Ramnath Kovind ji has urged the nation to keep the guard up against COVID-19. He has said that people have shown an unmatched resolve against COVID and must remain alert and continue taking precautions, which we are telling time and again. He applauded the medical professionals for fighting against the pandemic. हम सबको काफ़ी खुशी होती है यदि हमारे पेशेंट्स जो हैं, जो काफ़ी स्वस्थ हो जाते हैं किसी भी डिज़ीज़ से अगर वो ग्रसित हों। तो इसी तरीके से जब हमने लास्ट टाइम देखा जो डेल्टा वेव थी काफ़ी त्रासदी मची थी उस टाइम पे, चाहे वो हमारा देश हो या बाहर का देश हो। इसीलिए हमने सोचा कि इस रिपब्लिक डे के अवसर पे हम आपके सामने स्पेशल लोगों को लेकर आएँगे, जो कि एक्सपीरियंस है बाहर के देशों की, किस तरह रही कोविड के साथ उनसे पूछेंगे। तो हमारा टॉपिक ऑफ द डे जो आज का है उस पे चलते हैं। So, our topic for the day is COVID-19, the UK experience, and we have a very special guest with us whose name is Dr. Anand Singh. Now, let me introduce the guest for today to all of you. Namaste, Jai Hind, Dr. Anand Singh.
Namaste.
So, it gives us a
Namaste, Jai
matter of
Hind, and Happy Republic Day to everyone.
Yes, it gives us a matter of pride that you are here with us. You belong to
Thank
India
you.
basically, and you're now treating patients over there in UK. We feel really proud that you have been awarded the BMJ Respiratory Team of 2021.
Thank you, Dr. Kantu. Thank you.
सो अगर मैं डॉक्टर आनंद सिंह के बारे में आप लोगों से कहूँ, ये काफ़ी एक अपनी जो इनकी फ़ील्ड है, उसमें एक एक्सपर्ट हैं और ही इज़ अ रेस्पिरेटरी कंसल्टेंट एट वेस्ट हर्टफोर्डशायर hospitals in the NHS Foundation Trust in London, United Kingdom. He is the lead clinician for sleep and non-invasive ventilation. जो हमारे बाईपैप, सीपैप, ये जो छोटे वेंटिलेटर होते हैं, जब हम पेशेंट्स को उन पे डालते हैं, ये उसमें काफ़ी जो है एक एक्सपर्ट अपनी राय दे सकते हैं और उनमें इनकी जो क्षमता है काफ़ी बाकी लोगों से ज़्यादा है क्योंकि इस चीज़ में काफ़ी रुचि रखते हैं. He is a part of the team that won the prestigious BMJ Respiratory Team of Award in 2021. He is also involved in COVID virtual hospitals, यानी कि virtually जब हम पेशेंट्स को ट्रीट करते हैं, ऑनलाइन उनकी कंसल्टेशन करते हैं, ये उसके साथ भी जुड़े हुए हैं. His special areas of interest include interstitial lung disease, sleep and ventilation, and interventional pulmonology. He has an extensive experience of treating multi drug resistant tuberculosis and a passion for teaching and research and has written various resources for respiratory MRCP specialty service exam. He also mentors candidates to take up the European diploma in adult respiratory medicine. He has played a key role in the hospital committee dealing with COVID-19 crisis and setting up of high dependency unit, sorry, and was the lead respiratory consultant who managed COVID-19 patients with respiratory failure. जो पेशेंट्स अनफॉर्चुनेटली जो है ऑक्सीजन पे चले जाते हैं और उनको वेंटिलेशन की ज़रूरत पड़ती है, उस चीज़ में जो ये हैं हमारे डॉक्टर आनंद सिंह काफ़ी एक्सपर्ट हैं और काफ़ी पेशेंट्स को इन्होंने ट्रीट करके अच्छा किया है. He has published several papers in peer-reviewed journals and has authored several book chapters. During his career, he has received various awards and accolades, including the Star of Hearts Team Award by West Hertfordshire Hospital in 2021, Winter Warrior Award in Glenfield Hospital in 2018, to name a few. This is really commendable, Dr. Anand. You have received an award for Winter Warrior, services. So it gives me immense pride to welcome you here. So tell us more about you.
So, thank you very much for your kind words, Dr. Vidhi Kantu. Very kind words. I have to live up to all the reputation that she has spoken about, which is going to be difficult now. So, I mean, coming back to things, I think obviously February 2020, everything changed in the world. Like, we have obviously had viral pandemics before this. I mean, we've had influenza, different types of influenza. We've had SARS, which is like a type of coronavirus, but obviously it's different to COVID. So we've had these virus outbreaks before. There have sometimes been concerns about the MERS syndrome, but fortunately it never became such a global problem of a large magnitude. Fortunately, it never had this kind of an impact. I think some of the pandemic impact is a lot to do with globalization. It's to do with our lifestyle, globalization, how fast things spread from one country or continent to all the countries in the world. It's to do with our approach. So everything changed in February 2020. We were aware that there were few cases in Wuhan, China. We were aware that there possibly was an early signs of this spreading around to Italy and it crippling the health system over there. So we were aware of this. Should I speak in Hindi or English? Is that fine?
We are okay with both Hindi and
Okay,
English. Since
right.
our audience would be Indian, so you can use Hindi as well. आज
Okay,
गणतंत्र दिवस का मौका है, तो आप हिंदी
okay.
का इस्तेमाल बहुत अच्छे से कर सकते हैं.
ओके ओके सो अंटिल फरवरी के पहले मतलब देयर नेवर बीन अ इस तरह का वायरस पैंडेमिक कभी हुआ नहीं था. फरवरी 2020 में ऑब्वियसली वी न्यू दैट this is there in China, and as it was sort of evolving its way through Italy, we were not really prepared for this. I think no country in the world has been prepared for a pandemic of this magnitude. If I just talk about, it's not related to medicine, I'm just trying to make this a bit holistic, but people have had pandemics before, I presume, and it's never had this kind of an impact. So nobody expected this kind of devastation to happen. And none of the Western countries or any of the European, Asian, African countries, American countries, I don't think anyone was ready for such a pandemic like this. And I don't think any health system was actually ready to tackle a situation like this before, because they've never experienced this. Interestingly, if we look at it, there was it's not related to medicine. There was a movie called Contagion. एक मूवी था कंटेजियन करके, जो 10 साल पहले बन चुका है. वो वायरस पैंडेमिक और उसके कॉन्सिक्वेंसेस के ऊपर बनाया है. अब ये तो फिक्शन मूवी है, ये मतलब रियल स्टोरी तो है नहीं, ये बना है 8-10 साल पहले. अगर आप देखेंगे उसमें, तो आपको समझ में आएगा कि उसमें और अभी के सिचुएशन में कितनी सिमिलरिटीज है. मतलब ऐसे लगता है कि ऑलमोस्ट 90-95% थिंग्स आर सिमिलर. एनीवे, कमिंग बैक टू दिस, so we were not prepared for it. What happened is, suddenly one day towards the end of February 2020 or the starting of March, we had a couple of suspects of COVID in the hospital, and I don't think we had PPE at that time. Nobody knew what was the right type of PPE to have, and we had some people who were suspects with a viral illness. And suddenly, the weekend came, and then from Friday to Monday, we had a ward full of these patients, and within 2 or 3 days, I mean, I was in a different hospital then, but within 2 or 3 days, from one ward it became 3-4 wards, and then virtually within 10 days the whole hospital was full of COVID patients, and everything had come to a standstill in terms of elective surgeries, patients who were admitted for their other conditions such as uncontrolled diabetes, heart trouble, and so on. And the same thing happened in more or less all the NHS hospitals in the UK, and the same thing happened globally as well in Europe, and then it came to India a bit later. So I think we have learned in this thing that there is something called as disaster preparation and emergency response, which it's something that everybody talks about, and everybody is supposed to have a system to deal with it. But in reality, after this experience, I think all the healthcare systems in the world need to have a much better disaster preparation plan, so that I hope we never have a major pandemic as bad as this. I hope not. God forbid that never in anyone's lifetime. But if it does, we are all in a much better position to respond to it and reduce the consequences of this. The problem with which comes with such a pandemic is it obviously affects the patients who have the viral illness, whether it's COVID-19, but it also affects the health and care of those who have under other medical conditions. बिकॉज व्हाट हैपेंस इज, जो लोगों को दूसरे मेडिकल कंडीशंस है, जिनको अर्जेंट मेडिकल एडवाइस की ज़रूरत है, या तो उनको अपने फिजिशियन से कंसल्ट करना है हर 2-3 महीने, या तो उन्हें हॉस्पिटल की एडमिशन की ज़रूरत है. बट क्या हो जाता है कि उनको थोड़ा सा फियर हो जाता है कि इन्फेक्शन स्प्रेड होगा. जो हॉस्पिटल और डॉक्टर्स है वो भी कोविड पेशेंट्स को ट्रीट करने में ओवरवेल्म हो जाते हैं. तो ये एक प्रकार से इनडायरेक्ट इम्पैक्ट है कोविड का, और इसको हम इजीली मेजर नहीं कर सकते. ये तो न तो इंडिया में, न तो अमेरिका में हम एक्यूरेटली मेजर कर सकते इसका इम्पैक्ट. यानी कि अगर आप देखोगे कि सपोजिंग 2019 में पर 100,000 population you are expecting there'll be X number of heart attacks requiring admission to hospital. Now those numbers do not disappear in 2020 or 2021. Unfortunately, these illnesses will still be there in the community, but our fear and concerns are that a lot of these patients are not presenting to the hospital because of fear of catching COVID, or they may not be having, the hospitals might not be having capacity to treat these patients. I mean, no, that's not in the UK. In the NHS we always have prioritized this, but I'm talking about it more on a global basis. So there are sort of direct and indirect impacts of this. And then the other impacts of this, what I can say is that, it obviously, it can affect people's mental health in that sense. If there is a lockdown, a lot of people, restricted to some place, the lockdown is for various scientific reasons, and it is indicated, before, come to 2020, when we did not have any vaccines, we did not have any proven antivirals, we did not have any proven treatment which reduces the complications from COVID. Yes, people were using medications based on their judgment, but there was no evidence for it. So at that time, a lockdown was needed, and this has a lot of indirect, impact on people's, economic impacts, impact on people's mental health and various other issues. So it's not just about the direct impact of COVID-19, it's more about the indirect impact overall. So coming to this, should I continue, or are there any specific questions?
So I'll be taking up some specific questions from the audience, but let's
Yeah.
have your experience first. So as you told
Okay.
rightly
So
that no nation actually was ready to take up so much of volume load of the patient. So many people have been saying and criticizing a lot of governments, whether it would be the United States or it would be the UK or consider India. There has been a lot of politicization, as we say sometimes, of these kinds of problems which arise. US has condemned certain things in India. India has told them that, look, we are able to handle the pandemic better. People have been, mudslinging, and these things have happened. But if we consider, no nation was actually ready to accept so much of volume overload of patients, which happened at certain point in time when nobody was expecting it actually. So coming on to the difference between this wave, which is mostly Omicron specific, and your previous waves, how do you gauge both of these waves in your country?
okay, so we've had, I would say, I would call it as three waves. For From my experience in the NHS as a respiratory consultant, I would say three waves. The first wave was, when it came in on, our judgment of seeing what evidence was going on in Italy, because I think it's from China into Italy, and then it came to us. So the first wave was actually, I would say, the hardest in the sense, because it was a new disease, a new presentation of the disease, and the NHS did an excellent job by having the recovery trial, because we launched the world's largest randomized control trial to try and identify which potential medications can help. And we were involved in recruiting patients to that. So definitely this was something that, we were all learning in the first wave as to how this disease behaves. Because if you look at COVID-19, it's unlike any other respiratory illness seen before. There is something called as happy hypoxia. So a lot of patients with COVID-19 actually have very low oxygen levels, but appear to be quite well. They might look as well as myself or Dr. Vinny Kantru on the video. They might actually look as well as this, but the oxygen levels may be surprisingly disproportionately low. And it's a little bit baffling, because we haven't seen this in too many other illnesses before. So it was a lot of learning in the first wave. We had to act very fast. We had to create a high dependency unit in the hospital. Everyone did that. We had to expand our capacity to treat COVID patients. We had to identify which patients should be on, early on oxygen, which patients should be on non-invasive ventilation, which patients should be on ICU. And it was a lot of, strategy that was changing every few days, based on the presentation of patients, based on the hospital, reviewing the evidence available, listening to podcasts and experience of pulmonology colleagues across the world as well. And at that point of time, I remember, before I treated the first patient of COVID-19, I had looked to a few videos and, a few educational media resources posted by a lot of pulmonologists, especially from Italy and the US, because they had talked to us about their experience of using CPAP, where they said that CPAP was very helpful in treating these patients, and it avoids the need for intubation in some of them. So, yes, we were spending a lot of our time reading about this. So in the first wave, we as I said, we were treating patients, we were encouraging them to prone, we were giving them non-invasive ventilation as required, and there was also a sense of a bit of chaos everywhere because a lot of patients were panicking. I mean, I think I would still say that only a small proportion of patients with COVID-19 do require hospitalization. Not all of them do, but because it was such a new illness and it was causing a high degree of mortality, that is death rates and morbidity, a lot of panic was there. And the challenge, one of the challenges we would, I think the whole world health system would face, this is not related to any one country, is, everyone would encourage someone to isolate themselves if they had COVID-19 symptoms. And at the same time, one expects that if they require hospitalization, how would they sort of reach the hospital? So these are sort of little messages that are a little bit incongruent with each other, or they don't go completely hand in hand, because this was something new. But eventually, obviously, with the second wave, things got better. So come the first wave, we were doing the recovery trial. We learned from our experience that proning is very important. Steroids seem to be helping. Doing Giving them proning and giving them CPAP therapy along with the oxygen is really important. And because it reduces the need of going to ICU, because obviously there are some patients who do require to go on the ventilator. As the research was going on with the recovery trial data, the evidence came that corticosteroids, especially dexamethasone, reduce the complications of COVID, but it should only be given to patients who have got respiratory failure, यानी कि जो पेशेंट्स को ऑक्सीजन की ज़रूरत है, सिर्फ उन्हें इंजेक्टेबल स्टेरॉयड हम दे रहे थे हॉस्पिटल में. फिर हमारे पास थोड़े सबूत आए कि रेमडेसिविर helps patients. Remdesivir is an antiviral drug. What it does is it reduces the viral load. So if it is given early on in the illness to patients who have an oxygen requirement, it can help. It is not something that reduces the mortality or the death rate, but it is something that reduces the length of stay in hospital. So to high risk patients who are requiring oxygen, it was definitely being used early on in the NHS. And I think in different healthcare systems, you doctors have a little bit more freedom to decide on what medications they can prescribe. For example, in the UK NHS, we are bound by certain national guidance, and we can only prescribe patients drugs if they meet certain conditions. But I think it is a bit more flexible in India. And my colleagues like Dr. Vinny Kantu are probably able to, be a bit more flexible and use their judgment and discretion when required. So the second wave, by the time the second wave came, we were a lot more prepared for it because we knew how this disease behaves. We knew about the patients being hypoxic or having very low oxygen levels, although they may not appear to be so unwell clinically. We knew that steroids help these patients. We knew that antibiotics do have a role. Remdesivir does have a role. We knew that various methodology of various medicines had been tried. We also knew that tocilizumab, which is a drug usually used for rheumatoid arthritis, in the selected patients can definitely help to reduce COVID complications. And we had all that evidence. I mean, I think in India, the doctors have done a fabulous job. I salute them because I think they had been using tocilizumab quite early on, but there was no randomized control data to endorse that. I mean, I was in touch with various colleagues, and I knew from their experience definitely if you had patients who are in the cytokine storm of COVID, or who are in the sort of day 7 to 11 kind of complication time for COVID, tocilizumab could help in, obviously there has to be a thorough checklist for that, but it was working. And in the recovery trial in the NHS, we got the data to finally show that it helps. And therefore in the second wave we were a lot better prepared because we knew that steroids and tocilizumab together can reduce the complications to a significant extent, and we had a proper protocol as to which patients should get tocilizumab. We were pretty much aware of our ventilation strategy because we have generally, before COVID, we've used CPAP very rarely for treating any infections or respiratory failure. We have used CPAP therapy more often, to treat sleep apnea, to treat certain other kinds of infections, but usually they have never been in such large numbers. So it was a bit of sporadic experience. This is the first time that we treated hundreds of patients of CPAP in a few weeks. So the second wave came, we were ready, much more experienced with our CPAP treatment strategy. We knew that we have a few medications that work, such as steroids, such as tocilizumab. We were aware of some of the complications of COVID, although they are unusual. Like, for example, diabetic ketoacidosis, or somebody can present with uncontrolled diabetes because of COVID. We were aware that it can occasionally affect other systems in the body besides the lung. We were aware of the various complications it can cause in the lung. We were aware of what non invasive ventilation strategies we should use. For example, trying to lower the pressure, give patients a significant break. Because we learned that actually it does, if we use the non invasive ventilation at high pressures for a long time without break, it does lead to some complications as well. So we had got all this clinical experience and wisdom with us, and I think we were in a much better position as such. Of course, at this stage there were no vaccines. The vaccines came to the NHS in the UK around December 2020. That's when we launched the vaccination, and obviously it started based on the age and based on the healthcare workers. So I think it started with the people who were above 80 and the NHS staff then. So what happened is, with this wave, we began to see that it was too early to judge the impact of vaccination, because there were a very few proportion of the population who had received a single dose, and almost nobody had received the second dose of the vaccine before sort of February 2021. Almost nobody, although there might be a few elderly patients who did. So it was too early to judge the impact of vaccine. But what we realized from our experience was that the Delta variant was far more virulent than the original coronavirus 2. What that means is कि जो डेल्टा वेरिएंट था उसकी जो कॉम्प्लिकेशन रेट थे, यानी कि जो नंबर ऑफ पेशेंट्स, प्रपोर्शन ऑफ पेशेंट जिनको ऑक्सीजन की जरूरत पड़ती, या नॉन इन्वेसिव वेंटिलेटर की, या आईसीयू शिफ्ट करने की जरूरत पड़ती, वो नंबर्स पहले ही वेव से काफी ज्यादा थे. It was more virulent, and I think this was the experience globally as well, even in India, because I think even in India the Delta variant caused a lot more problems and complications as opposed to the original coronavirus. So, but in the second wave, we were better prepared for it. And what happened is, I think in January 2021, sort of around 1st January, actually, that's when the NHS declared a critical incident, because that's when the admissions had surged so much that the number of patients in hospital had surpassed the number of patients in the first wave. And we were realizing that most of them were very unwell. By the way, just to come in here, in my hospital in West Hertfordshire Hospitals, which is just on the periphery of London, we were one of the first hospitals in Europe and possibly in the world to develop what is called a COVID virtual hospital, which was the brain or the idea of some of my colleague consultants. What they did is, in the first wave of COVID, sort of around May 2020, they had this idea that there are so many patients of COVID, and only about maybe 3 to 4% of them might need hospitalization. The rest might need reassurance, checking of the oxygen levels, a very objective scientific phone call from a doctor or a nurse specialist to make sure they are not having any complications that warrant admission. And they had a checklist. So this is how they began in April, May 2020, with a hope that it would prevent the hospital wards and the whole hospital from getting overwhelmed. And it worked to a large extent. So this was all going on in the background since April, May 2020. So come the second wave, the COVID virtual hospital was still on. Our treatment strategies were, we had more information about that in terms of the pharmacological treatment, in terms of non-invasive ventilation experience, and the vaccination program was rolling out. So this wave subsided by March to April. Things got better. Then things started opening up, and then it was things were stable-ish. I mean, they were not at a peak of things in the first or second wave. They were stable-ish. We did have a few patients coming in, of course, but the third wave is, what began with, I would say, with Omicron. With Omicron, initially when it came, there was a bit of, we did not know, I mean, the South African doctors and scientists had shown us their data. They believed it was a mild disease. In most patients, they thought it was related to the upper respiratory tract, and it was less likely to cause respiratory failure. This was the data that they gave us, but everybody was apprehensive because this is a new disease, and everyone thought there might be a few factors which are different in South Africa as compared to other countries. For example, you know in South Africa, there had been a lot of South African variant, and perhaps there might have been cross immunity for that, because that was a slightly different variant to the alpha and the delta variant. Likewise, when it came to the UK, we did not know what happens, because there is a causative effect. When it spreads for 2 to 3 weeks, the infection spread. Then 2 to 3 weeks later, you see hospitalizations, and then 2 to 3 weeks later, you start to see all the complications from hospitalization rising, like deaths. So there is always a lag of 4 to 5 weeks from when you have rising number of infectious COVID patients, and from the time that you see the complications, which is why we adopted a very uh, I think a balanced approach. The government made some restrictions, and we were trying to get data and analysis, analyzing what the impact was. In the third wave, there was a significant difference in the NHS, because between the second and third waves, almost, I would say, more than 80% of the adult resident population had been double vaccinated, and a lot of patients had received the booster, that is the third coronavirus vaccine. And as Omicron came, the plan was to expedite or to rapidly speed up the vaccination program, and eventually they offered the third dose, I believe, to everyone who was above 20 years of age. And even I think those who were between 12 to 20 years were offered either one or two doses of the vaccine, depending on their underlying conditions and their age. So I think what happened is, in the third wave, we were the best prepared for everything, because there's a saying, once bitten, twice shy. We were aware from our experience that do not underestimate our opponent. You one thing that you learn in sports, like whether you like cricket, football, tennis, never underestimate your opponent. Always be well prepared for something. Never be caught off guard. And this is something that the pandemic did to the whole world. But we weren't going to repeat that mistake again. So this time we were quite well prepared. We were thinking that the hospitalizations are going to rise, the complications are going to rise, but fortunately that never happened. Like, there was a clear difference in, when I looked after the COVID high dependency unit in, say, the first week of December, and say the last week of December or the first week of Jan, there was a huge difference. Like, it was visibly a very different picture. Like, because when I looked after it, say, in the first second week of December, there were a lot of, in the high dependency unit, a lot of unwell patients, who were here for medical reasons, requiring a high amount of oxygen, requiring non-invasive ventilation, who would all need to go to ICU. Most of them were double vaccinated. We hardly had any triple vaccinated who were unwell, except for certain high risk patients. And a vast majority were actually, at that point, in December, we had some statistics saying that about 90% of the patients in ICU were unvaccinated. And about 90% of patients who died from COVID were unvaccinated. And this is pretty much what we were seeing. The disease definitely, before Omicron, we could definitely see the difference in the presentation, that those with the Delta variant were affected much more severely if they were unvaccinated. Now, in 2 to 3 weeks, come the end of December, early Jan, we could see that the same high dependency unit treating COVID patients, the patients were actually a lot milder. We do not admit patients unless they have a need. So, most of the patients who were here were actually those who required a milder amount of oxygen, or they came off the oxygen more quickly. They did not land up going to ICU or hospital because of some other reason which required admission, and they were found to have COVID at that time, because it had spread a lot. What we found from our analysis in the NHS is that the Omicron variant is probably about 7 times more contagious than Delta variant. And in terms of causing hospital complications and the worst complication, that is death, it's probably between 35 to 70% less likely to cause these complications. But it is 7 times more contagious. So this is what we found out. But by the time this data came out, it was sort of late December and early January. So again, our experience in the third wave was, we were treating patients who were either in the unvaccinated group, or if they were adult patients, all of them were double or triple vaccinated. And by now, we knew what the treatment strategies were. We knew steroids work. We knew there are antivirals available. We knew there is tocilizumab, and we knew that these patients are less unwell. Come December 2021, in the NHS, we announced a slightly new advanced strategy to get patients in the community two kinds of medications. So we have molnupiravir, which is I think now available in India as well. So we have molnupiravir, which is an oral antiviral available. The if data and the statistics show that it reduces the risk of hospitalization among COVID patients by 30%. We also have what is the antibody cocktail available to treat this. Now, the antibody cocktail is basically the Regeneron or the Ronapreve. It is known by different names in different parts of the world, but it is essentially the same antibody cocktail, Regeneron or the Ronapreve. This was being used by us to treat these patients who did not have an antibody response. And we have launched a clinical trial called the Panoramic trial. In the Panoramic trial, we are basically allowing outpatients to patients who are well and otherwise at home in the community who've got COVID-19 to enlist in this trial, and they are eligible to receive molnupiravir. Obviously, it is compared against placebo, so basically just to look at the efficiency of this. So in the third wave, our strategy has changed because there are a lot more treatment options available. If they do come into hospital, we look at their vaccination status, we look at their antibody levels, we look at if they did not have an antibody response, we would consider giving them the Ronapreve Regeneron antibody cocktail. This is if they had the Delta variant. We now know that the Ronapreve or Regeneron antibody cocktail does not work against the Omicron variant, so we do not use it against the Omicron variant. In fact, we have stopped using this in the NHS since about 3.5 to 4 weeks, because by the end of December, close to Christmas, Omicron was the dominant variant in the UK. To treat Omicron, there is another synthetic antibody available. It is called sotrovimab. Now, I don't think this medication is launched in India yet. I hope it will come to India soon. Sotrovimab has been shown to reduce the complications from Omicron variant of coronavirus, and it definitely has data to support its use. Again, there are very limited number of patients that who really need to get this. So our experience in the third wave again could be divided into the pre-Omicron surge and the post-Omicron surge. Pre-Omicron surge, we had the antibody cocktail, we had antiviral steroids, we had tocilizumab. But once the Omicron surge happened and it became the predominant variant, we could see that the acuity of care or the magnitude of patients being unwell had definitely fallen significantly. And we could see that very few patients would actually need significant, very few vaccinated patients would have a long length of stay in hospital requiring non-invasive ventilation or ventilation. Having said that, a word of caution to everybody in this uh, conference is that obviously vaccination reduces the risk of complications. Nothing in life is 100% effective, nor is vaccination. The most important message you can do to protect yourself and your family and your dear ones is get vaccinated, and as appropriate, whenever your local healthcare system or government is offering you the booster, obviously go and have the booster as well. That's what is the take home message for you all. And with Omicron variant, may be more mild, definitely, but it is also more contagious. And there are some group of patients who are very high risk and who are susceptible to develop complications from this. So there are patients who may be elderly or who may be slightly younger, but with certain conditions such as those who have transplants, or those who are patients on drugs that support the immune system, or patients who are having some type of cancer for which they are on active treatment with chemotherapy. These patients are those who are pretty high risk. There is a whole list of conditions actually. In the NHS, we have developed a pathway to use the synthetic antibody treatment, which is now sotrovimab, or to use molnupiravir for a group of patients who fall in the high risk category. So we have made this list a group of 9 to 10 conditions. Like we've got a list of conditions of the lungs, of the heart, of the kidneys, of various other things that make of certain neurological problems that if they have one of these conditions, they are eligible for this treatment. So this is how our strategy has changed. And now with the Omicron variant, we find that the symptoms obviously are quite different. That's another thing to tell you about, because the classical symptoms have always changed. With Omicron, from our experience, we believe that people can present sometimes with only fatigue, sometimes with a sore throat. They may not always have the classical symptoms of cough, loss of smell, breathlessness, and so on. So the symptoms or the manifestation can be very clinical.
Right. Am I audible?
Yeah, yeah.
Yeah, so it was a very nice overview of all the three waves of your country. We have actually had the same kind of experience. Now, to go through the questions of the audience, I'm glad we have a lot of people who are associated with us at the moment. Kamya Sharda ji, Dr. NNS Sharda, he always logs into our session. We welcome you, Dr. Sharda. Savita Bhutani ji, good evening to you also. Aruna Tyagi ji, good evening. Anamika, good evening to you also. Nidhi Sidwani ji has a question which I'll be taking up. Since you were talking about the sotrovimab, which we reserve for our high risk patients, although this kind of monoclonal is not available at the moment in India, but in future I am sure it will be available. Just quick few questions which Dr. Prakash Wadhwani was also asking. Prakash ji, we did touch up that monoclonal antibodies which work against Omicron in high risk patients is at the moment sotrovimab, and the rest of them are being tested. About this thing, so how do you differentiate between the Delta and the Omicron? Do you already have the test kits which differentiate between these two strata of people at your NHS center, or you don't just test them with the Omicron
To be
specific test?
honest, we have. If I'm honest with you, I mean these are my views. I don't like represent the hospital or the whole NHS. Obviously, these are my personal views as a pulmonologist, Dr. Anand Singh. We do not. We have not doing. We've not been testing for the variant since 2 years now, because of the fact we know that Omicron is pretty much the predominant strain in the UK. We are 98. We are sure that 98 to 99% of cases of coronavirus are due to the Omicron variant. So we have stopped testing for whatever variant it is. That's the
All
truth.
right.
Like, yeah.
So,
Initially,
right.
initially
So,
before it had reached such a magnitude, they were testing for it, but we stopped. And I support that strategy. I mean, I think it makes sense.
right. Because
And this is the reason
Omicron
why we
is
have stopped.
actually replacing
Yeah,
Delta.
because
Yes.
this is the reason we have stopped using the Regeneron or the Ronapreve antibody, which is your casirivimab and indevimab. We stopped using it because
Yeah.
we know 99% cases are due to Omicron.
And do you use the 3-day remdesivir therapy early on in patients who are high risk to go on to severe disease?
Remdesivir on the NHS, like there are in the NHS, it is approved for patients of COVID who have respiratory failure. So if there are certain criteria, for example, someone who has COVID-19 who's got respiratory failure, needing some amount of oxygen, who and this is I'm talking about the wave 1 and wave 2 strategy. Then I'll tell you from a wave 3 onwards. Wave 1 and 2, we used to give remdesivir to patients who are hospitalized with COVID-19, who have respiratory failure, who are within 10 days of the onset of symptoms, who do not have significant liver derangement or kidney derangement. Basically, we needed the EGFR to be more than 30. We needed the liver enzymes to be less than 5 times the upper limit of normal. So broadly speaking, these were the sort of inclusion criteria for giving remdesivir in wave 1 and wave 2. In wave 3, our strategy changed a little bit. It is part of a treatment, but because we had steroids, we had the vaccination, and because we had tocilizumab available, we were not giving so many patients remdesivir. Our aim was, to identify the seronations and give them antibody cocktail if they are seronegative, if they are seropositive, and if they are in the cytokine storm window, and if we have ruled out bacterial infection by doing the procalcitonin and there are no other complications, try and give them tocilizumab. So this was a strategy, and somewhere in the strategy to use the antibody cocktail and use tocilizumab to treat the cytokine storm, remdesivir went like further down the packing order. Like from being an opening batsman, it went down to number 3 or number 4. We did give it to some patients. For example, if I had a patient who is a 65-year-old with COPD requiring a high amount of oxygen with COVID, whose antibody response is positive, so we cannot give the antibody cocktail, and somebody whose procalcitonin is positive, saying that they have a mild bacterial infection. Now, this patient can't have tocilizumab, so I would give this patient remdesivir and steroids. But if there was somebody who could benefit from the antibody or tocilizumab, that would be our plan A.
Right, very
Right.
good. So it's down the list, but it's still there. Glad to know
Yes.
that. केदार जोशी जी, नमस्ते आपको। केदार जोशी जी का एक बहुत ही इंटरेस्टिंग सवाल है। ये पूछ रहे हैं कि आप जो रिस्पॉन्स है इंडिया का एज कंपेयर टू यूके और यूएस, उसको कैसे आंकते हैं? हाउ डू यू गेज द रिस्पॉन्स ऑफ इंडिया अगेंस्ट दिस पैंडेमिक एज कंपेयर टू योर नेशन और टू सम डेवलप्ड नेशंस?
I mean, to be honest, I'm nobody to be passing judgment on that. I think let Dr. Vinny Kantru answer that. I think every system, every country has its pros and cons. Okay, nobody is perfect. No country, no healthcare system is perfect. There are always some advantages in it and some disadvantages in it. So I would not like to. I would just say that first of all, we should remember all the patients and all the colleagues who have lost their lives in this pandemic globally, whether in India, UK, or wherever. So we should remember them. We should respect the efforts and salute the efforts of all our colleagues. It's not just doctors, nurses, healthcare assistants, everybody in the hospital. And I think we should remember that we are all in this united. We are not here to kind of create some kind of rating that, oh, this person gets a gold medal, they get a silver, and they get a bronze. I think that's not our sort of approach. Our approach should be to have a, for the future and for the current scenario, should be to have a very unified platform where the leaders and the doctors and scientists of very well developed countries, India included, communicate on a basis to share their knowledge, share their ideas, so that it helps one another. I think that should
Right,
be our aim, so that the doctors and
perfectly.
scientists should communicate for a condition like this. I hope there's no such pandemic again, but I suspect at
Yeah.
some point it might happen. And there should be a platform, like where the world leaders also have a sort of hotline to each other, and they take measures in a more proactive way with first-hand experience of each other. I think that should be our take-home message, rather than compare, who's done a better thing and not. I mean, on reflection, we can always say, we will always identify scopes for improvement in the first wave, second wave, in the healthcare system, and in us as physicians when we are practicing. But it is very easy to say that with 2 years of experience doing this, isn't it?
Right, definitely so. So definitely, Dr. Anand, I agree that people have been asking this question and again, considering the fact that they think that developed nations are better equipped to deal with certain kind of patient, strata. But the fact of the matter is that the numbers had increased to such a large extent that even the hospitals which were constructed were not actually tailor made to cater to this kind of large rush of people in any developed nation also. So as compared to that, vis-a-vis that, so India didn't do a very bad job considering the amount of population which we have here. So we have a large population, and to cater to each and everybody, going to the grassroots, especially with the vaccination, has been commendable. For that, I am proud to be from India, and of course, Dr. Anand, you would also say that you're proud to be an Indian. So we are
Of
all
course.
proud of each other. Yes, medical
Yeah.
community has actually done a very good job, including the paramedical staff who have done everything possible. Nidhi Sidwani Diwan is connected with us. She has a question. She says, I had my first dose of Covishield. I saw after second day a clot in my finger and arm. I don't think that should have been a clot. It should have been a bruise or something and little red spots. Please suggest me about my second dose.
I mean, look, there are rare complications which can happen with medications, with vaccines, and with disease as well. Like, I think this should not be seen as a as a personalized consultation, because I think one has to go through all this. Say for example, what happened, whether there was any clot, any circulation. I mean, this is a general note, and I can't kind of do a personal consultation in front of a whole audience, because I think the most important thing here is that there are some complications which can happen. Blood clots from vaccines are a possibility. But they are very incredibly rare. The chance of getting blood clots with the AstraZeneca or the Covishield is incredibly rare. It's about less than 1 in a million. But the chance of getting blood clots if you get COVID and you get admitted to hospital is far more than that. if someone has developed a significant complication from this, usually we encourage them to report it through a channel, which is like an adverse system reporting. Like we have a yellow card on the NHS. I presume in India they have a similar system of reporting it. So one should encourage that to be reported. If you show your physician who evaluates you at that time, they could consider doing a few blood tests to see if your certain cells in your blood have dropped. They can consider doing any scan as well if they think it is necessary. And they might also want to, it's better you show somebody in person. They can also consider checking your antibody levels, and then they can advise you. So I think it is a combination of these things. Like whether or not that is related to the vaccine, it is a rare possibility. They would need to do some blood tests, they would need to examine you. And if one can always consider reporting this as an adverse event, but always remember the take home message, that complications with vaccine are possible, they are rare, they are like a blood clot from the vaccine is probably less than 1 in million. But we know the percentage of patients who are on ICU or the high dependency unit with COVID, the risk of blood clots in these patients is about 15 to 20%. That is 15 or to 20 out of 100 who are extremely unwell with COVID have blood clots. So it's about balancing the risks. I mean, everyone has to make an informed decision. I mean, what we talk about in the UK or the NHS is an informed decision, because we have faced ethical dilemmas like, if somebody has developed a complication from this, do they get the vaccine, do they not get the vaccine? And in difficult cases, we can always give them the advice, like, this is your antibody level, have they had COVID or not, what are the possible complications to them in the future. With the Omicron variant, again, the complication rate is probably lower than the other variants. So these are all things to bear in mind, so that one can make their own informed decision after having all these facts.
Right, Nidhi. So there is a system in India also that you can report to the center where you had your vaccination. आप वहाँ पे जाइए और उनको बताइए, उनके वहाँ पे जो नर्सेज हैं, जो पैरामेडिकल स्टाफ है, वो आपको देखेंगे कि क्या प्रॉब्लम हुई थी, और यदि कुछ ऐसी प्रॉब्लम है तो वो डॉक्टर को भी बोलेंगे आपको देखने के लिए। उसके बाद आप डिसाइड कर सकते हैं कि आप अपना सेकेंड डोज लेंगे या नहीं लेंगे। इसके अलावा हमारे पास ऐसे कई क्वेश्चंस आ रहे हैं। पीपल हैव बीन आस्किंग दैट इवन आफ्टर टेकिंग 2 doses of vaccination, whether it was the Covishield, which is the exact replica of the Chad vaccine in UK, or whether it was the Covaxin. We have seen a lot of patients getting affected with the Delta wave, although we did not see much number of patients who actually lost their life. But unfortunately, Dr. KK Agarwal did lose his life due to COVID. He was doubly vaccinated. And a question to you is that have you seen such people, dying out of COVID in the second wave, even after they had their second vaccination?
Okay, so the truth is, in general, vaccines are meant to reduce. First of all, our sincere condolences to Dr. KK Agarwal's family. I'm aware of that very sad event. With vaccines, we are aware that the main aim of vaccines is to reduce the risk of hospitalization, death rate, and life threatening complications. Like I said, they are probably 90 to 95% effective if we look at the Pfizer vaccine after 2 doses, but they are not 100% effective. So if you think of it, like when we give a simple analogy, in India, when we give the BCG vaccine, that is the TB vaccine at birth, to everybody, which is given on the shoulder, usually at the left shoulder, it is not something that prevents TB. It is something that protects and reduces the more life threatening forms of TB that can have devastating consequences later on in life. Because in India, TB is a problem. We give the TB vaccine to everyone, but it protects them from life threatening complications of it. And if it prevents someone from developing these life threatening forms of TB, it's done its job. Okay, but even then its efficiency is not 100%. So coming back to the vaccines, yes, we have seen people who have been admitted and had complications, who were single vaccinated or double vaccinated, but they represent the tip of the iceberg or the minority of cases. In Because what I can say is a correct fact, that all the patients of coronavirus are treated in the NHS hospitals. So when we have the statistics by looking at the death certificates, we know that 90% of the deaths with coronavirus were in the unvaccinated group. versus 10% in the vaccinated group, which shows that it is 9 times more likely that not getting the vaccine is 9 times more riskier to die from coronavirus than getting the vaccine. That is just to simplify it. In terms of looking at the third wave and with Omicron, what's been happening, because in the UK, everybody has been offered the double vaccinations, and most have been offered triple vaccine based on their age, of course, because those who are less than 20 do not probably qualify for 3 doses unless they have some exceptional medical conditions. Okay, so in the third wave, our experience is again that those who are unwell are those who are the unvaccinated ones or those who have not had the third dose. Those who have kind of, who were offered the vaccine but they did not prioritize it, those are the ones who are more unwell. So yes, we have seen patients. I mean, in the UK, we have a different set of vaccines. The AstraZeneca or the Covishield is same. We also had the Pfizer vaccine, which was used. India has Bharat Biotech or Covaxin, which I believe from colleagues is an excellent vaccine. I mean, I have no doubt about it. A lot of my colleagues have been praising it, and they have been saying that it works wonderfully well. So there is no doubt the Bharat Biotech Covaxin award is vaccine is very good. The Covishield is very good, and I believe there are various other vaccines in India, including Sputnik, and a few more are Johnson and Johnson is due to launch. I don't know if they are available, but I know that they were approved. So our vaccination was a bit different. We had Pfizer, which is the predominant vaccine, along with AstraZeneca, and we do have some doses of Moderna. They also have the Johnson and Johnson vaccine as well, which was being used. In terms of giving the booster, the UK government and the NHS launched the booster program. It was always an mRNA vaccine. That's the Pfizer or the Moderna vaccine. Only those individuals who were having a allergic state where they developed some kind of an allergic reaction to the Pfizer or Moderna vaccine, these people would be offered an alternative such as the AstraZeneca vaccine. So that answers your question. Yes, we have seen some complications in those who are vaccinated, but the risk of complications is far more in the unvaccinated. The risk of dying from COVID is probably about 9 times greater in the unvaccinated. So we would encourage everyone to get vaccinated to protect their near and dear ones.
Right, definitely. So, a burning question now from Kedar Joshi ji, Dr. Anand. Everybody has been asking this, whether it is abroad or India. Everybody wants to know whether will be any kind of fourth wave and when this pandemic is actually going to end.
I think only he knows. No, God knows. Okay, but coming to this, I think uh, I would say that there are few important things here. You know, it's we have learned about the disaster preparation and being aware of this. The good thing is, I hope sincerely. I mean, look, these are my personal views. I don't represent the hospital or the NHS. My personal views. I think in the future things will be a bit better because people have been vaccinated. Okay, in India, everyone is being the booster program is being launched, but I understand some people are due to have the second dose. My concern is more about global fairness and equitable distribution of vaccines. I mean, I believe that this can end and we would be heading towards making it an endemic if all the countries with a slightly lower GDP, lower socioeconomic strata get an equitable proportion of vaccination. And United Nations has been stressing on that, but not everyone has been sort of pooling their share of vaccines, medications, and money. So I think the effort should be to try and make sure the vaccine reaches most countries, involve the local sort of there may be a bit of lot of misinformation which is spread from various media outlets or spiritual wrong messages. So try and involve the local leaders, whether they are sort of government leaders or other public figures in all the countries. Try and get the vaccination numbers high throughout the world. That would help a lot. But I think the future wave should be better because vaccinations are there. The promising data is that Pfizer is doing a trial in the US on people above 50 years of age for its updated vaccine, which is meant to tackle the Omicron variant. I hope, fingers crossed, that the results and the data is promising, and then I hope like other vaccine makers will be able to follow suit as well. And I hope, why not? Why with the Serum Institute in India, with Bharat Biotech doing a fabulous job, I'm sure if you give them a few months, they will be able to update their vaccines as well. But obviously we need to understand that they are doing this under an immense amount of pressure. I think one needs to give them credit when it is due. Also, I think it needs a bit of political measures to sort of encourage research and development. You need the government to incentivize companies to be doing R&D, that is research and development, so that when situations like this arise, those companies are ready to tackle it by increasing their production or testing facilities or manufacturing to help us cope. But I think the future waves will be better because we have better medications available. We have oral antiviral pills available, like Molnupiravir. Molnupiravir is there in the UK, US, in India. India has Favipiravir, which now is probably being replaced by Molnupiravir because Molnupiravir is available much more easily as well. We have injectable antivirals, we have steroids, we have tocilizumab. We know our treatment strategies. We have the vaccine. So I think hopefully the future waves will be less severe and have less of a devastating impact. But the other bit is also, learning to live with COVID. I think that is also something that has to be considered, because I think if you look at the UK approach, like I think it's a very balanced approach. It could have been considered that what the government did on, say, 18th or 20th December by not locking down was, in the eyes of many people, as ridiculous or outrageous. I mean, yes, the virus did spread like water. I mean, there was some estimate in around the week between Christmas and New Year. There's an estimate that 1 in 10 people in the 1 in 12 had the virus at that time. But now people will probably get immunity, so I think it should help for some time. Of course, I understand that the levels of immunity are different in different countries. It depends on how many people have been exposed to the disease and how many have been vaccinated before. But I suspect the future waves will have less of an impact. And I think the important thing is to be united in this, where the doctors, scientists share their knowledge, and these companies who are developing vaccines should receive certain benefits from the government, or certain measures to enable them to expedite their manufacturing and research for this. And I see that as a very important step.
Definitely, Dr. Anand, I do agree on all of your points. Hopefully, we have milder kind of disease now from now on. Because the Omicron has actually virtually replaced the Delta variant, and we should in future get only these kind of milder waves. And also, more importantly, the virus should not mutate to a level where we are not able to catch it. So hopefully our government of India and our scientists are working on the upgradation of vaccine. We are very elated and happy that we had an elaborate discussion with you about the handling of pandemic of COVID-19 in the United Kingdom. And we are extremely happy that we learned a lot of things from you, including our audience. So, a lot of thank you to you for today for taking out time and joining our session. Everybody has been they're praising you because you have explained each and everything very lucidly. Nadisha Puriji is associated with us. She says it was very informative. Uday Shankar ji says it was very informative. Nishad Natarajan very well explained. Rohit Khera uh, explained very well, could understand everything. Chitra Natarajan, every aspect well covered and explained very well. Thank you, Dr. Anand. So, from our
Thank you.
end, we present to you this small
Thank
token
you.
of appreciation in the form of this certificate. Could we just show the certificate to Dr. Anand? Thank you so much. So, this is a very small token of respect for you for so many awards which you have received. And in future also, we wish you receive a lot of accolades and awards and keep helping people. Thank you so much for joining
Thank
us
you so
today on
much.
this
Thank you for
Republic Day.
inviting me. Thank you.
Thank you.
Thank
So
you.
happy Republic Day to you and Jai
Happy
Hind to
Republic.
everyone.
Jai
Thank you.
Hind. Thank you.